All right, we're going to begin. Thank you for joining us today, everybody. You are at Supportive Housing and Medicaid, positioning your agency for success. We know that the road to recovery for those experiencing or facing homelessness begins with housing. We also know resources are scarce. Agencies must do more with less, and providers must maneuver through a seemingly endless list of rules and requirements in order to fund and deliver housing plus services to those in need. Many agencies are now taking advantage of new opportunities to use Medicaid dollars to help pay for supportive housing services, and this requires a new set of rules, processes, and requirements. Today's webinar is hosted by Foothold Technology and the Corporation for Supportive Housing, and we'll discuss the ever-changing federal landscape and how it affects the way supportive housing agencies can operate and the importance of strategies for working with managed care organizations. In case you missed the first slide, this is just a text slide to teach you how to use our WebEx system today. If you have a question, we welcome them. Please click on the chat button on the top right-hand side of your screen, and be sure to send your question to all attendees or all panelists. If you are having trouble with audio, the best thing to do is just to close the window and relaunch. I also posted the directions to obtain your call-in number in the chat box. And we are recording today's webinar, and that recording and the materials will be emailed out to all registrants after the end of this webinar. A little bit about CSH. We're a national organization with regional offices and staff throughout the country. We focus on supportive housing and housing solutions to improve the lives of vulnerable people. We also help communities maximize their public resources through creating supportive housing, and our ultimate goal is to build strong and healthy communities. And a little bit about our other host, Foothold Technology. Foothold Technology's Electronic Record Awards is among the most widely used systems for supportive housing agencies across the country. Foothold powers the Supportive Housing Resource Center, a hub for industry news, and the Supportive Housing Resource Exchange, an online forum facilitating a conversation among those in the industry. Awards is a fully interoperable with federally certified systems for participation in health information exchanges, and is the only record-keeping system that is certified as both a behavioral health EHR and a homeless management information system, HMIS. And today's presenters are myself, Tim Ng from CSH, Marcella McGuire and Terry Power from CSH as well, and Paul Rossi from Foothold Technology. And with that, I'm going to pass it over to Marcella McGuire.
All right, thanks, Paul. And thank you, everybody, for joining us today. We're looking forward to the conversation. And as Tim said, please, any questions, et cetera, please type them in the chat box. We'll either do them while the process comes around, or we'll have them at the end. If you work in the homeless system space, or if you're learning about the homeless system space, this is a really important fact. Communities have until January 23rd of 2018 if you received HUD COC funding in order to shift to a coordinated entry system. This is really the absolutely on-the-ground implementable way that we're moving from a diverse collection of programs of independent providers that employ a lot of different ways and a lot of different methods and a lot of different uses in order to achieve a lot of different goals. So we're shifting from a very diverse and different system into a really systemic homeless response system, an integrated network of providers that coordinate efforts in order to achieve maximum impact. And the piece that means to most to me is that making sure, and most to CSH, is that making sure that both vulnerable individuals, those with the most challenges, the most disabilities, are not locked in that system. But it is really shifting a change from each provider deciding who they're going to serve, what they're going to serve, how they're going to serve them, to a more systemic response where we have to look at the community and make sure that the community has options for everyone who needs homeless resources, whether that's rapid rehousing or that's supportive housing and other needs. And also the community is able to, in a systemic way, roll up their needs, particularly their service needs, and say, this is what we need, this is how this is working, this is how it's not. So coordinated access has a shift from people experiencing homelessness go to a particular program, they're served by that program, or they're not. That other program may or not be connected to other programs, in order to a real systemic response that assesses people through a coordinated assessment process, and then determines that individuals move to I'm sorry, I just saw that note about we're not hearing anything. that, Tim, I want to make sure folks can hear me here. That's just the one person who will fix it. Okay, great, good. Okay, so we're shifting from programs to a coordinated access system. Individuals are assessed, and then individuals are assigned to a particular program. So it's not each individual program, a shelter, permanent supported housing program, making a determination. It's really getting those referrals from the coordinated entry system. And for the supportive housing providers, be aware that as I look at all of these options in this coordinated response system, the most intensive services, maybe not as intense as needed, but the most intensive services that are available are under the permanent supported housing model. So permanent supported housing models will be getting folks with the most significant challenges. They will have the highest level of service needs. They will need services from multiple systems most likely, and will need a level of service coordination. And we'll talk today about some of that. It's important to know that the primary funder for services in communities is the state Medicaid system. Now, if your state has expanded Medicaid, that means that almost everyone in your community, except for folks that are undocumented, are likely to be Medicaid eligible. They may not be enrolled, but they're eligible. And what services each state offers differs from state to state. What services are offered in your state are considered under your Medicaid state plan. That Medicaid state plan is an agreement between the federal state government, what's called CMS, Center for Medicare and Medicaid Services, and the state. Each state is required to have a designated state Medicaid agency. That Medicaid state plan defines what services are offered, who those services are eligible for, what populations, and define how people access those services. If states want to make changes in their state Medicaid plan, they can make changes through something called state plan amendments. They are amending the plan, or state waivers. They are asking to waive a particular aspect of the Medicaid program and offer something else instead, and then they have a good reason for that. This will increase the health of our population. This will improve outcomes for particular beneficiary group. This will save costs for the state and the federal government. So if states want to make changes, and there's lots of detailed processes there to make those changes between state plan amendments and or state waivers. States commonly administer Medicaid in this manner, and it's good for you to learn these things about your state and figure out how your state makes these changes. Each state should have a dedicated state Medicaid agency that is the lead, and then there are often agencies that work closely with the Medicaid office with more specific, maybe program information or data information. Most states' Medicaid programs will have something like a healthcare authority, Office of Medical Assistance Programs, Health Choices. You'll hear these as well. They may also have a subgroup that has behavioral health administration. Behavioral health is really an umbrella term, meaning mental health is substance abuse as well. They may have input into your state Medicaid plan, particularly around mental health or substance abuse services. Your state Medicaid plan may be in the Department of Social or Health Services. This is true in Indiana, where you've got FSSA, a Department of Human Services, and maybe that's the overall umbrella organization. There'll be a developmental disabilities division. They'll work closely with the state Medicaid office, particularly on Medicaid waivers that serve people with intellectual or developmental disabilities. And then your state may also have an aging department, what sometimes they call the AAAs. And that is where often you'll find the expertise around long-term services and supports. So these are common state structures for administering Medicaid. They all have input. The most common structure we found is that the state Medicaid office primarily is knowledgeable around Medicaid regulations, Medicaid policy, and then also understands the fiscal implications of Medicaid, works with the budget office there, and then the program pieces are often farmed out to other offices, behavioral health, the health department, aging or LTSS services as well. It's important for your state as you begin this process to understand who these players are in your state and begin to understand how they work and what opportunities they offer for your agency. If you want to learn more about your state, there's a link here, how do I learn about my state, at the CMS website, and there'll be information state by state. Each state will have a page. Each state will also have information on waivers and state plan amendments, both ones that have been approved by the federal government as well as ones that are being discussed at this time. CSH is particularly excited about the number of states that are looking at waivers to serve tenancy support services, or what CMS is also calling foundational community supports. This is state work in response to a 2015, what's called an informational bulletin from CMS that says, while CMS cannot, or Medicaid cannot pay for room and board, cannot pay for operating subsidies, cannot pay for rental subsidies, they can pay for the supportive services that allow people to obtain, maintain, and sustain housing over the long term. Louisiana and Massachusetts both have programs that have been around for over a decade. The states after that, Indiana, Maryland, California, Washington, New Jersey, and Florida, all have recently approved amendments. By recently, I'm in the next 6 to 8 months. Maryland may be the furthest along. They've got a request for proposals out. So if you're in any of those states, there's a possibility that tenancy support services or foundational community support services are included in your state Medicaid plan. There may be a way in order to connect there and look for funding from your tenancy support services. A number of states have waivers that are currently pending at Center for Medicaid: Illinois, Hawaii, Rhode Island, Pennsylvania, and Michigan. And then finally, states that are considering waivers. You also see a list there as well. Some of the waivers are what are called 1115 waivers. These are research and demonstration waivers. Other are 1915C or 1915I waivers. These are long-term services and supports waivers. If these waivers are approved by Medicaid and put forward by your state, then these services are offered. It's important to understand how the system is structured so you understand where it is that you're looking for funding from. I would say that most of these states are managed care, states, so that you will be contracting directly with a managed care organization rather than a particular rather than the state office. If your state office primarily offers their services through fee-for-service, what's often done as FFS, then you'll be talking to a particular state office who does that if you're looking for supportive services. If you are looking for, but if you're a state that has managed care, if your current tenants or your prospective tenants and residents have Medicaid and they're covered by managed care organizations, then they're members with managed care organizations, then those are the entities that you begin to want to look with and connect to. This is just a chart to tell you how Medicaid and managed care enrollment has grown. We're looking at this point, 39 states use Medicaid, are primarily covered through managed care, and you'll see the numbers here about how high that is. It's also expected to grow. Medicaid costs are a great concern to state budgets, and states commonly turn to managed care in order to try to manage those costs. There are a number of resources we have here. CSH and the United States Interagency Council on Homelessness has a quick guide to improving Medicaid coverage for supportive housing services. We've got a link to the CMS Bulletin on Tenancy Supports. We've got a white paper for states that didn't see, if you didn't see your state name on that list, about creating a Medicaid supported housing services benefit. This is a framework for Washington as other states. And then CSH has a regular, we update this about once every couple of months, a listing about where states are, state actions on Medicaid and housing services. So please take a look at those. Our contact information will be in the back here as well. And also feel free to check on the, if you've got questions in regard to your state, where your state is in that process, please feel to be in touch with me, and we'll look and try to figure out some of those together. So thanks so much. And I think at this point, there's also 3 other resources that you can find. CSH has a website with all of these details on it, csh.org/health. There you'll find our guide to services funding and supportive housing. If you have more questions, housing is the best medicine, how supportive housing is one of the key social determinants of health, and finally some details on how to build health and housing partnerships. All right. And for now, for questions, but I think I am moving, and I don't see questions, just some comments. And so I think I will turn it over now to Terry. Terry, I will pass you the ball.
Oh, actually, Marcella, I got a question did come in privately.
Okay.
It's my state did not expand Medicaid. Should I still work on the transition for my services funding?
So yes, good question. The answer to that question is yes. we have found in many states that there's still a significant number of people who are experiencing homelessness, experiencing chronic homelessness, supportive housing residents. I know in one project in Texas, we found that about 30% of the individuals, in Texas is a non-expansion state, we found that about 30% of the individuals were enrolled in Medicaid upon admission to supportive housing. Another 30% of those residents were able to be, were eligible but not enrolled, meaning they hadn't gone through the bureaucratic processes to get their Medicaid turned on. Once they were stable enough thanks to the supportive housing program, they were able to change that. So that's really a hopeful possibility. If you're a current supportive housing resident, supportive housing provider, it probably behooves you to do a survey of your residents and determine how many of them are Medicaid eligible, how many of them are Medicaid enrolled, and look at what those percentages are, and that can help you make some of your decisions. I would say if you're running anywhere from 40% or higher of your residents are enrolled, and as supportive housing targets the most vulnerable, the folks with the greatest needs, that's very common, that those folks still will be Medicaid eligible and or enrolled, that you still really probably want to move forward with some of this.
Great, thank you.
Okay. Thank you, Marcella, for that amazing, all of that amazing information. But before I start, I'm going to introduce myself, but I want Marcella to introduce herself too, so you all know who was providing all of that information.
Thank you, Terry. I just get straight into the information. I get so engaged by it. Marcella McGuire, I am the Director of Health Systems Integration for CSH. I'm based out of Philadelphia and working with communities across the country as they begin to put supportive housing into their Medicaid plans and work to expand supportive housing, both capacity and quality, through working with Medicaid and managed care organizations. Thank you, Terry.
Great. Thank you. So I am Terry Power, as Tim said in the beginning, and I actually work in the Ohio office. Marcella, as she said, works for the national office of CSH. We have both. And one of the reasons that I do these webinars is prior to working at CSH, I worked at Volunteers of America, Greater Ohio, and I took them through a CARF accreditation, a state certification, and then a Medicaid contract. And so I have lived this world and this change and transition. And so I'm going to take it from the high level of where Marcella was down to a little bit of detail. Because this is just an hour webinar, I certainly can't get into all of the detail of these items, but we are going to look at, just briefly, some of the things that it's important for you to consider if you are looking at billing Medicaid. Your target population, the type of services that you deliver, paperwork, your staff, your finance department, and how you currently bill. And we're going to talk really briefly about quality improvement and the costs and the benefits. So in terms of services that you provide, it's really important to assess and evaluate the type of services that you are currently providing to your clients or your tenants. And part of how I think is important to assess or evaluate this is to actually have conversations with your staff about it. What kinds of interventions would they say they did? What type of case management do they deliver? What interactions do they use? And so just through your conversations with staff, I think you'll be able to determine the type of services that are being provided. Then I think it's important to look at the volume and the frequency. So how often do your staff see the clients on average, and how much time do they spend with them at each appointment, again, on average. At VOA, one of the things that we did was a time study, because sometimes I think it's hard for staff to actually know how do they spend their week. And so I had them do a time study for, I think it was a 2-week period. there are many different ways that you can do a time study. We did literally in every 15-minute increments. They had to write down what they did. And it was telling for me and the supervisor of the program how much time they spent in travel, for example, how much, because we were a scattered site program, how much time they spent in paperwork, in data entry. And so I think it was very telling for everyone, probably a good thing to do whether or not you bill Medicaid. And then the location of services. And again, at VOA, it was a scattered site model, so I would say 80% of the services were done in the homes of the clients. Occasionally, the clients came to the office. And then once you do that evaluation, you need to look at your services and ask the question, can they be certified? Can they be Medicaid compliant? What will it take? What services are we already doing that are Medicaid compliant? And we'll just need very, very little tweaking. And the staff are doing a good job at those services. If not, what will it take to get those services certified or compliant? And then I think it's important to assess paperwork. I will say that I probably could spend an entire hour just on paperwork and charts and HIPAA. But again, this is just a brief overview. I will say this was probably the most difficult change for staff. We spent a lot of time on paperwork. It was a big transition. VOA was not, other than the local COC, in the very few times I think that HUD came, no one was really looking at Volunteers of America's charts, and there was no audits or anything like that. And so it was really a change and a big learning curve for them. And in terms of paperwork, I really mean all of the forms that you are currently completing. So it would be from if you do the diagnostic assessment, from that to the service plan, your progress note, your termination forms, your transfer forms, your consents. So you really need to look at all of your paperwork. And then, and again, evaluate, what will it take for them to be Medicaid compliant? What revisions do you need to input? And then how can you help the staff with those changes? Location and security of charts. When we became certified at Volunteers of America, we had paper charts. I'm not sure what they have now, but if you do have paper charts, it's important to have them in, a secure location, in a file cabinet outside of the area where clients walk or where they are, in electronic files, which I think most of us will be going if we're not there yet. It's important to have all of the login securities that you know are important, and that staff follow the protocol of those security processes. And Foothold may certainly talk more about that with their system as well. We aren't going to go into HIPAA in this presentation, at least CSH isn't, but I would definitely make sure that you understand HIPAA and that you have people that you can refer to, an expert in the field. It is an expert. It is a specialty. Even with attorneys, it is a specialty, so I would recommend that you make sure that you are fully informed and have people that you can ask questions to. In terms of the golden thread, that refers to the importance of the story that your chart tells. So what you want is you want the diagnostic assessment to really flow into the recommendations. So based on what that person's symptoms are and their diagnosis, that's the recommendations that are made. Then from there, you develop goals and objectives on the service plan, and from there, you can see the progress in your progress notes from your sessions with your tenants or clients that really look to or connect to those service plan goals and objectives. So that's what's meant by that golden thread. There's a connection and there's story being told from the diagnostic assessment through to the progress notes. And when someone comes into audit records and looks at records, they're looking for that piece. And the other thing they're looking for is that documentation and requirement of the medical necessity, and that's why it all starts with the diagnostic assessment. That diagnosis becomes the foundation for the medical necessity that is being provided for that tenant. So it's all, as I'm sure you've heard, if it's not written down, it didn't happen, and it's the same way with this. And it does need to flow and make sense from the diagnostic assessment through to the progress note. So the golden thread is one thing, and the medical necessity is a different piece in terms of making sure that it all connects to that diagnosis and makes it medically necessary, the intervention that you're providing. I apologize for my throat. I have a little sore throat. And then staffing considerations. So you want to look at your current staffing, their licensure, the degree they have, the level of experience and expertise that they have in terms of, and look at it in terms of your Medicaid plan and what is required, if any of that is required specifically. Depending on the service that you are getting certified, that will probably depend on the level of licensure and skill and degree that you are looking at with your staff. So obviously, completing a diagnostic assessment would require a different level of licensure than providing case management services. Counseling would require a different level of licensure and degree than, again, case management type services or tenancy support services. So know the services that you want to get certified, and then make sure that you're looking at the licensure and skill and expertise of your current staff. Some staff can get training, and that may help, and that may suffice a requirement, and some may not. Again, with VOA, we did have some staff that ended up electing out, and they did not make it through the transition, and some staff did, and we were able to get them up to speed through some clinical training. Because of their years of experience, they were accepted. Caseload size, you need to look at. Medicaid does require a lot of documentation, a lot of checking. There's going to be reviews and chart reviews, so caseload sizes may need to be smaller than they were. And the other thing I want to say about caseload size, and when we talked earlier about the volume and the frequency of seeing clients, one of the things that we did at Volunteers of America to even see if this was going to be worth our while when we look at the value, we very conservatively looked at how much we thought we could bill based on caseload size and time spent with clients. I didn't want the quality of our care to our clients to in any way be diminished or at risk. And so we did conservatively look at that. So caseload sizes may need to go down. Supervisors, again, you need to make sure that you are compliant with Medicaid and what, or managed care, and what they would require in terms of supervision. And not just in terms of licensure and degree, but also it's important to make sure that your staff have the right amount of supervision based on their degree, their licensure, their years of experience. And it's important that they are provided with the appropriate amount and kind of supervision. I usually recommend individual and group, because I think there's things that you can learn individually with a supervisor, and I also think there are very special things that you can learn through group supervision. And then training. One of the things I want to say about training is I always look at training as two different types of training. One training is what I would call clinical training, so it is basically what does your state or managed care require that your case managers have or your counselors have. And again, it may be dependent on their level of expertise, their years of experience, their degree, and their licensure. Because VOA was also CARF accredited, CARF also had requirements on training. Again, it was dependent on the number of years of experience staff had, and their degree and their licensure. So we worked with HR to come up with a training calendar and who needed what when, and they were helpful in continuing to remind us of who needed something in their first 30 days or 90 days or when it was annual training was due. And then the second kind of training is what I alluded to earlier in terms of documentation. It's really important that enough time is allocated to training staff with the culture change, with the documentation change, with the change in audits and reviewing charts, and that they are really ready for that transition. As much as you possibly can, it's important to get staff feedback, staff buy-in. Even if they disagree with some of the changes, it's important that they get their say and that they're able to vent and express themselves as much as you can do that. So that's what I mean by two separate kinds of trainings. Your reimbursement capability, one of the things that I didn't say when I began this that I usually say is doing a Medicaid contract is really a commitment from the entire agency. It isn't one program supervisor, one team in isolation of the rest of the agency. It's really a commitment from the entire agency, including the board. Now, of course, with VOA, it was definitely an agency commitment because we had to obtain CARF accreditation first. And so the board is definitely involved in that, not just in cost, but there are a lot of standards related to overall administration and boards when they come in and review your agency. And so I say that to say that your finance department is also needs to be involved. And so the program staff and our finance department at VOA, we met several times and looked at how our finance department currently billed, who were our funders currently, how did we bill currently those funders and get revenue, and how different would it be or not if we were going to bill Medicaid. In the case of Volunteers of America, billing Medicaid was very, very different than anything else that VOA did in terms of billing. At the time, and I think still, Ohio is a per unit billing, so it's fee for service based on the number of units. And we did not bill anyone that way. We were mostly just a cost reimbursement. So we decided that it was best for us to contract with an outside vendor who had the right software to bill the state. She was a contractor for other smaller organizations that couldn't afford to buy the software that was needed to bill the state, and so she was very, very experienced at it. And that was a great decision, I think, for VOA, and I believe that she's still even doing the billing today. I just want to talk very briefly about quality improvement. You can't have a Medicaid contract. You can't move forward with any kind of certification or accreditation without a quality improvement plan. And it's a good thing to do anyway. I do want to say a few words just about quality assurance and quality improvement. They are different. Quality assurance is more about making sure that you are compliant. It's more about reviews, chart reviews, checking to make sure that things are done correctly and that you're maintaining that compliance. Very, very important. Quality improvement is more about collecting data, strategizing about things that maybe you can do better or gaps, and then collecting information and doing something about it. So they're very different, and I believe both are needed. This is a very typical, what I call closing the loop in terms of quality improvement. The plan is about the strategy that you can use to either look at a current problem, look at gaps in your program, look at aspects of your program or your services that you would like to change or revise or improve. And so that is what you focus on, and that's your plan. you gather as much data and information about that strategy as possible, and then you do. So you implement. The doing is the implementing of the plan and of that strategy. It is the steps and activities that you use once you've identified your strategy and your plan. It's important that when you are implementing, you have a specific way of collecting data while you're implementing and making sure that you are collecting relevant data. And that means that you have to check in, and that's where the check comes in. You can't, I think a lot of times what we do, and I know that I've been guilty of this myself, is that we may have a strategy and then we just implement it, and then after a year or two, someone may ask, how'd that go? And anecdotally, maybe you could tell them, but you really need data to reinforce what the result was. Was it successful or wasn't it? And so the checking is making sure that you're stopping, you're taking a look at what you've done, you're looking at your progress, you're measuring the effectiveness of it. You're actually also measuring or looking at the data. Was the data you collected the right data? Did you collect it in the right way? Did you collect it as often as you need it to? So you're looking at the data too. And what is the data telling you? Which gets to act. What is the data telling you? Were you successful? Did it do what you thought it was going to do, or did it do something totally different? And based on the results of that data, then you act. So you may revise your plan. You may totally drop it. You may move forward exactly like you are because it's going really, really well. But it's based on that data that you have accumulated and reviewed and analyzed. And then the loop continues. And then these are just items that, or categories that are important if you're going to have a QI plan, which you're going to need to have. These are sections or categories that you can include in your plan. They're certainly not inclusive of all categories or sections, but these are the things that you want to look at. First, again, all levels of staff need to be involved, from your direct service staff up through your supervisors and managers and directors. Your QI plan needs to include a process or a step-by-step for reviewing your policies and procedures. Also, while you're going through your Medicaid certification and accreditation, there may be policies and procedures that you need to revise, add, or delete. And those are the things that you need to do during that process. Once those policies are revised and completed, you need a process for how are you going to review those. A part of your QI plan needs to talk about staff training. You need to talk about how you're going to maintain compliance. So it's not just about obtaining compliance, but also maintaining compliance. And how will you be assured that that's going to happen? You want to, as part of your plan, have a schedule of chart reviews and audits and the entire process, from when you review the chart to getting information to the staff person, to making corrections, to reviewing the corrections, all of that entire process. You want to have a section on outcomes, what your outcomes are for the program, how you're going to measure that, what you're going to do with that information. And then, of course, stakeholder input. Surveys that you will do with your tenants or your clients, and also external stakeholders as well, doing surveys with people that you work with to make referrals, either to you or that you're making referrals to, and other agencies and entities that you interact with on a regular basis. You would want to get their input as well. One last thing that I want to say is one of the things that will make this much better and much more successful is if you have a person in charge of the QI process. Not make it someone's job who already has a full-time job. So I would not recommend that it is the job of the current supervisor who, of course, already has a full-time job, because it will not get the attention that it needs. So that would be also an investment as well. And one of the, I don't have a slide on this, but one of the things that I want to say is then in the end, I think it's important to evaluate how much revenue that you think you can generate through the services that you provide and the cost. Because as you saw through those slides, there will be cost. With VOA, there was also the cost of the CARF accreditation as well as everything else. But in the end, we were able to hire an entirely new staff person. So we hired a licensed social worker who worked with, this was a family program, she worked with the children. We saw that as a gap in the program. And I also believe that we were just a higher quality program in the end, in general, going through all this process. So I will answer any questions as I pass the ball to Paul from Foothold.
Hey, Terry, one question that came in is how long did it take for Volunteers of America to get the Medicaid contract?
So that is a good question, and sometimes I forget to mention that. So it was probably a 2-year process. I think it might have even been 2.5 years. It might have been a little shorter if we didn't need the national accreditation through CARF. CARF and any national accreditation makes it a little bit more complex. However, I will also say that once we got CARF accreditation, there was a lot of standards from the state that we were exempt from. And so it made our state certification process much, much simpler because once they knew we had CARF accreditation, there was only probably a handful, 4 or 5 standards that they needed us to respond to separately from our CARF accreditation. But it's a long process. I would say it was about 2 years. And then once we got the Medicaid contract and started billing, there was a lot of errors and processes we needed to change. So we spent that first probably 3 to 6 months while we were billing, working out that process as well.
Great, thank you.
All right, Paul, I think you have the ball.
Okay, great. Thanks, Terry. So, I was introduced as Paul Rossi, and I am Paul Rossi. I'm the Director of Client Services at Foothold Technology, and what I do with my team at Foothold is to help communities implement both homeless management information systems as well as electronic health records in individual organizations and also in collaborations. And I want to talk to you today more about actually what Terry was talking about, but as you start to implement that into an electronic health record or an electronic record keeping system. So I'm happy to be part of the conversation to share with you some of our insights into some of the challenges and successes, frankly, that our organizations and others have had transitioning into a Medicaid and managed care environment. So there's a couple of key components, and I was glad to hear Terry hit on all of them, actually. Organizational leadership, having a really strong team in place, planning for challenges, and data management are absolutely essential. In terms of organizational leadership, making sure that everybody's on board with the overall goals, which are improving the health outcomes, improving the quality of care, and reducing costs. And sometimes that involves reaffirming your mission. Terry talked about, commitment across the entire agency, because it really isn't just about one program, it really is about the organization. And in some organizations, that alignment already exists, but really more than ever now in this sort of managed care and Medicaid environment, having that mission be clear to the entire organization is really key. And it's the service team, it's the administrative support, the fiscal and billing folks, executives, the community, your board, and the clients or consumers that you're serving. Really need to understand what you're about and what drives that organization. In terms of coordinating care, Marcella kicked us off with an overview of coordinated entry within HMIS, and very similarly, in communities, there is care coordination across both homeless and non-homeless service providers as part of the larger service community. Being clear about your organization's role in that larger community of care is extremely important. Everybody needs to know what role they play so that the system functions well. Exposure to oversight really relates to the level of accountability that increases, both I think from within the organization and also from the outside. The organization is going to be subject to a much higher level of audit and oversight. The accountability is really heightened, and making sure that your team is aware of all that's required and expected of them is really key in that process. Teams need strong leadership. They also need to be really nimble because change happens all the time. It's inevitable. And they really must be prepared to shift directions in response to changing demands and changing culture. It really is a difference when you are billing, local funders, state funders, that sort of thing. It's a much different environment when federal dollars are involved through Medicaid and then through the state agencies that Marcella had highlighted initially. And at the same time, we're shifting from volume to value in managed care and with Medicaid. So it really does impact the way teams need to perform. Terry talked about quality assurance and understanding requirements. Having a strong understanding of everything that is required and expected is really critical. The regulations that guide the work have to be understood and really followed to the letter. The documentation requirements, timeliness, and appropriateness of the services that you provide really do play a huge role in this new landscape. And while everybody is, likely accustomed to some level of supervision and oversight within their existing operations, accountability in managed care is really heightened. Everybody needs to be clear on their role and comfortable performing it. And we'll talk in a few minutes about reviewing staff and assessing their appropriateness for their roles in this new environment, like Terry had alluded to. Data really becomes more important than ever. Terry suggested that some of you may still be on paper, and that is likely the case. We, currently work transitioning folks from paper collection environments to electronic records. I don't believe that you can participate in providing the kinds of services and documentation that you need to for a managed care environment and do that on paper. You will certainly have some paper components, but I cannot imagine a world that would enable you to remain exclusively on paper, entirely on paper, and still get done what needs to get done. The understanding what you're collecting and how you're using it in terms of a data focus is really key. Everybody needs to understand this. We're going to speak more about the data culture in a second, but what's really important is that the organization really start an authentic organizational focus on data. It really needs to become ingrained in the culture of the organization. It just can't be an occasional report or some reliance on a few numbers here and there. It really is important to understand what every aspect or what every piece of the organization is doing and how what they're doing is impacting the entire organization. There's bound to be a few bumps along the way, and I think that planning for challenges helps. There we go, advancing the slide. There are a few challenges. You heard earlier about team reviews, and really what that is, it's more about assessing the team, understanding or making sure that everybody understands what their role is, and really more importantly, that they're equipped to perform in that role. Terry mentioned credentialing and licensing and education. Those are all really key things to be aware of, and not everybody will be equipped to sort of continue along the journey with you. That's an unfortunate reality, but it's a necessary part of what's happening. In terms of knowledge gaps, learning as much as you can. It really is an entirely new landscape, and learning what others are doing, what you're expected to do, how are others innovating in your community or across the country, what's really expected of your team and your organization. Care coordination and being active in the community is critical, and so is also being open to learning a different way of looking at what you think you might already know and do well, and doing it a little bit differently. Maintaining momentum really speaks to the fact that, we talked about change and nothing stays static for very long. There's always going to be changes. So we want to make sure, or you want to make sure, that your team doesn't really get stuck in a routine or fall behind in skills or knowledge. Everything needs to be moving forward all the time. And in keeping with that, a learning culture is really critical. Ongoing training, team reviews, assessments, it's all really important stuff. Interacting with others in the community, or like we said, across the nation, engaging with an organization like CSH, those kinds of things are really critical to keep everybody learning, to keep everybody as sharp as possible. And the data that we spoke about earlier will drive a lot of this. And when we talk about data and we talk about data management, we've talked both about electronic health records and we talked a little bit about HMIS at the outset. Really, I work with data all the time, and our role is to help people collect data. So it's going to be a little bit longer on this slide than perhaps on the others, but it's really never been as important as it is today, and it's really never been the focus of so much discussion as it is today. Certainly as we've made the shift to electronic record keeping and away from paper-based data collection, the technology has advanced, and it's given us tools really that are so much more accessible to non-tech folks. One of the things that I think we find interesting about our work is that most of I would say the overwhelming majority of implementations that we do with clinical staff as opposed to technology staff, because it really is about requirements, it's about program, it's about workflow, it's about how the organization works. You're really outsourcing the technology, so that's the least of it, but really understanding how to integrate the technology into your environment is what's key. It's likely that most of you are probably already participating in a homeless management information system, or HMIS, in your community, and it's probably likely that you have some secondary kind of system, whether it's a homegrown database or some other kind of off-the-shelf product that serves as an electronic chart or an electronic health record within your organization. And while there are tools like Foothold Tim mentioned at the outset that, we're both an EHR, electronic health record, and an HMIS, for many of you, you might find that an HMIS implementation might not be the right place to be managing your data for managed care and Medicaid billing. Most HMIS systems, it's beyond the scope of what they do, and it's also an issue of whether or not you would want to maintain the level of data that you need to for managed care and for Medicaid in a system that you're not the system administrator for, and that other folks from outside of your organization might have direct insight into. So that's something to consider. And the data that you're collecting certainly should have a role in informing leadership about how programs are operating and how service delivery is impacting your client outcomes. And, as Terry really mentioned, regular review of that data is essential. Everybody needs to understand the data, and everybody needs to understand the role that data plays. Billing and reporting, getting paid is a really important aspect of this whole delivery, or this whole endeavor, rather. It makes the delivery of the services possible. And getting paid for legitimate and allowable expenses is super important. Folks that go through their first Medicaid audit and billing audits learn about disallowed costs and clawing money back, and it is, disallowed costs. It can be just hugely problematic for an organization. So that, again, the data quality, data review, and a plan to continuously improve performance and your audit readiness based on those reviews is really essential. The collaboration part, within an HMIS, certainly you have the ability to share data. Within an individual health record, you have the ability to share data across your organization. And oftentimes you'll be connected to like a regional health information exchange or, something that will allow you to share data with a medical community, a little bit beyond the scope of what we're doing here. But having all of that information in a single system really does support collaboration across your organization. Terry happened to mention that they implemented programs in scattered site environments. So, paper charts and scattered sites don't necessarily go hand in hand, but electronic charts work nicely across different locations, even, different geographies. And I think that one piece of data use that's often overlooked is really about using data to tell your stories and the stories of those that you're serving. And we hear so much more about this now, that organizations are getting more sophisticated with data and the tools that are available to tell stories. And I think that there are a lot of resources out there now that are really geared towards helping you understand the stories that you have to tell and how to sort of mine some of that data from within your records and from within what the organization is doing to make that more accessible and to make it something that you're able to integrate into your operations. And that's really what I have. And based on the time, I want to stop there and see if perhaps there are any questions or if there are any comments from others on what we talked about.
Paul, one question that came in is, it sounds like Medicaid-funded programs need to collect much more information than our agency normally shares in our HMIS. Can you talk a little bit about how they could keep using their HMIS as their primary case management system and still do everything they need for Medicaid?
Yeah, so it gets challenging, and I touched on that a little bit earlier. You know, again, if an HMIS, you know, first of all, it's a requirement for most folks. So it's the option to not use an HMIS is not one that's actual. What we typically see happen is an organization that's participating in an HMIS but finds themselves with a greater need for an electronic chart or an electronic health record within their organization is oftentimes able to sort of pull out of the HMIS, if you will, as a primary place for this data collection, collect the data within their organization, and then HUD has created some standard tools, some export standards that support moving data back and forth. So those organizations oftentimes have the ability to share data, the HMIS data that they collect in their individual electronic health record or electronic chart back with the HMIS. It's at the discretion of the HMIS, of course, but it is something that's possible. We have seen people bill Medicaid out of an HMIS, and again, I think it has to do with the sort of the culture and comfort that you have in having that level of information available in an HMIS, which is often administered by the HMIS lead agency, which is usually not part of your individual organization. So that information is sort of out there in another database. You need to think long and hard if that's a good idea for your organization.
Great, thanks. And then one more question was, our agency doesn't employ any medical staff. Do we have to hire nurses or doctors and have them on site in order to bill for Medicaid?
So you don't, and I think that perhaps Marcella might be able to, or Terry could even contribute to the answer on this. Because of the waivers that Marcella was specifically speaking about in the beginning and looking at supportive housing as like a social determinant of health, there is a little bit of a difference in terms of the kinds of things that you can get paid for and the level of staff that can do that. But the short answer is no, you don't need to hire nurses and doctors and have them on staff to bill Medicaid. Marcella, I think I heard you unmute. Do you have something to add?
You did, yeah. That's a really state-by-state question. Each of your states will have, first there's a conversation to be had about what service you're trying to bill for. So you're trying to bill for case management, or you're trying to bill for peer recovery services. And then states will usually have requirements, often they're called licenses, that has requirements about who you have to, what supervision is required, what training is required, what background is required. And then managed care also has what they call their credentialing requirements. Paul, what you said earlier in regard to a lot more requirements here, absolutely key and true, but it's really a state-by-state question. So yeah, and we've seen a lot of supportive housing providers also partner with local federally qualified health centers or partner with a hospital, partner with a residency program. You're not going to be going out and hiring a doctor for 40 hours and they're going to be full-time with your staff. Just the cost of that is absolutely prohibitive. There's a lot of sort of creative ways where you can find out exactly what is required and then at least meet those minimum requirements as you're beginning to start up. You may need more than that, depending upon the people you're serving and the services you're offering, but that's something you want to get some more experience under your belt before you do that.
Great. So that's all I've got, Tim.
Yeah, I'm not seeing any more questions, so I will go ahead and do the wrap-up. So this training is brought to you again by Foothold and CSH, and CSH has a couple of upcoming trainings in December. Our first is Successful Supervision for Supportive Services Staff on December 12th, and then Billing Medicaid for Supportive Housing Services on December 14th and 15th. If you're interested in registering for these trainings, you can do so at csh.org/training. We are going to be having a Medicaid Academy called Your Agency Medicaid. It's one of our signature training experiences, and the CSH Medicaid Academy will prepare a group of providers in a community to enroll with Medicaid to bill for covered services in order to maximize billing and draw substantial funding to pay for services. And in the interest of time, I'm going to skip forward a little bit. I'm going to do a plug for our summit, CSH Summit 2018, which will be in Los Angeles, California from June 5th through 7th. Registration will be opening in a couple of weeks, but we are putting out a call for proposals. So if you or your agency has any great ideas for a presentation or a session, please do submit one at csh.org/summit18. And I want to thank our presenters today, Marcella, Terry, and Paul so much. And thank you all for joining, and have a great rest of the day.